Hello and welcome to this month's edition of Successful Physicians Monthly. I'm your host, Jamar Brown. Today I will be speaking with a true innovator and champion in healthcare, Dr. G. Richard Olds. Dr. Olds is a graduate of Case Western Reserve University School of Medicine and trained in internal medicine at the Massachusetts General Hospital in Boston. He was an infectious disease fellow and one of the nation's first geographic medicine fellows at University Hospitals of Cleveland, where he also served as medical chief resident and a faculty member. Dr. Olds has received numerous awards and is known as an educational innovator. In 2010, he became Vice Chancellor of Health Affairs and founding Dean of the School of Medicine at the University of California in Riverside. Dean Olds, welcome to the show.
Well, thank you.
I appreciate you being here today. You know, you have a very interesting background, which is a combination of traditional training in medicine and also some non-traditional training in terms of working in third world countries. Can you kind of speak to that?
Well, I do have a fairly traditional background in my training, and I have a fairly traditional background in both basic science research and population-based research. But the unusual aspect is that I'm a tropical disease specialist, and so I spent most of my professional career on the faculty of medical schools, but actually working in third world countries, usually on diseases of poor people in poor countries. And that gave me an unusual perspective of how developing countries with very little resources were able to do a great deal to improve the health of their communities.
Okay, and what are some of those things that you learned that was different or unique that you felt could be applied in traditional first world countries?
Well, clearly they look at the expenditure of money very differently. So when you think about our own country, you know, we have obviously, when we are at our best, we have an outstanding healthcare delivery system, but our problem is that we're not very efficient at delivering that to everyone. So how does a little country like Costa Rica, with 1/25 the U.S. per capita gross national product, how do they outperform the United States in virtually every measurable health outcome? Life expectancy, infant mortality, childhood immunization, maternal mortality. They do it by spending money on wellness and prevention. They see the value of keeping people healthy rather than letting them get desperately sick and then saving their lives at the end. It's a good skill to have. We plan to teach that, but you know, more emphasis on the cost-effective interventions. You know, you don't have to have a CT scan on every corner. You know, you have enough CT scans to actually get the appropriate studies for people that are needed. So one of the things I've learned in developing countries is that they're much more careful about how they spend their resources. Okay. They also have a much greater challenge in their own manpower needs. Take the Philippines, a country I've worked in for over 30 years. We in the United States steal virtually all their nurses and about 80% of their doctors. So what do they do to train some Philippine doctors that will stay and deliver healthcare to their own country? And they've obviously come up with some pretty innovative ideas, which I blatantly stole, as we try to address very similar issues in inland Southern California.
Okay, well, let me ask you this. With that background, is that what really attracted you to UC Riverside and becoming the founding dean of the School of Medicine?
Well, clearly that background, you use whatever background you have to try to help you do any job. I think the thing that I was particularly attracted to in UC Riverside is our mission to basically improve the health of the community we serve. Now, you would think that that would be the mission of every med school in the United States, certainly every public med school. It is not. And I think that that's a perspective that everyone in the United States has to begin to work toward. And interestingly, is a perspective that is being driven increasingly in the future by the implementation of the Affordable Care Act. So I saw an opportunity to do what I thought was the right thing to do, but maybe more importantly, build a med school based on where the future of healthcare is going rather than what was true 50 years ago, and train doctors differently for that reality with different skills, different platforms. And the University of California, Riverside was willing to take a more radical look at what we're doing based on their unusual missions.
Okay, and what I'd like to do is break down the mission of the school, because I think it's very unique and it's different from other med schools, as you said earlier. And the first part of the mission is to improve the health of the people in California or in the community. And you mentioned how that directly reflects the importance of looking at healthcare in the future. So can you kind of combine those two things in terms of the importance of the mission in helping to improve the health of the local population and how that is important for the future of healthcare?
Well, let me just touch on a few of the key things around the improvement of health for a community rather than the improvement of health for individual patients, a somewhat different perspective. We are structured differently than all the other med schools in California. All the other med schools in California have built large tertiary referral university hospitals, and they basically have their own physicians, et cetera. Although those are outstanding institutions, they're largely built on a competitive model in that they directly compete with the doctors and other hospitals in their own community. We are the first community-based medical school, so instead of building our own university hospital, we basically partner with the existing physicians, the existing hospitals, the existing federally qualified healthcare centers to try to raise the boats, if you will, for everyone. And we place our faculty with any of our various partners to work together around common goals of providing access to healthcare, improving the quality of healthcare, and recruiting and retaining physicians in desperately needed areas. So that's a difference in the structure. We also believe, as I previously mentioned, that we need to be more focused on wellness and prevention and chronic disease management and ambulatory care rather than always hospital-based care. So we've restructured the school to have more of that focus. And we also need, as an academic institution, we need to have the science behind how do you improve health for a community, and that requires us to recruit world-class scientists that can help us guide what interventions we do, what really gives us better bang for the buck, how do you actually improve the healthcare of a community. There's a science in that, and we're going to develop that type of science as part of the scientific basis for our medical school. So those are all things that I think are all different about us that are really almost exclusively focused around that, how do we improve the health of the community we serve.
It makes a lot of sense, but I know that anytime there's change or something new, there's resistance. When you look at trying to work with a model of collaboration versus competition, which is different, as you were saying, how was that adopted by the physicians, by the community, by the hospitals in the area? Was it readily accepted, or was there resistance to that idea?
Well, once they believed that we were serious about that, we've had fantastic support. So I think they was a little skeptical of whether we really meant that. But you can imagine that all the doctors in the community have actually welcomed us, both in San Bernardino and Riverside County, for a couple reasons. One, clearly there's a huge shortage of doctors. So in contrast to other environments, there's not nearly the competitive angst because if you're out there practicing and there's way more patients than you can possibly take care of yourself, you kind of welcome some additional physicians out there, different than an environment where there are actually too many physicians and you're all competing for patients. So it helped a lot that we have a huge physician shortage in this area. I think that the hospitals also like the idea that we would help them be more successful in doing this rather than competing against them. So virtually all the hospitals got on board early on. And the best evidence for that, unfortunately, came from the fact that we struggled to get state support. And we actually got to a certain point 2 years ago where there was no way we could actually open this medical school unless I came up with an alternative financial support for the school, alternative to new state money. And our community stepped forward and basically we raised $100 million, $10 million a year for 10 years, largely from the hospitals and foundations and doctors and people in our community that believed enough in what we were doing that they actually put their money on the table. And that is probably the best evidence that we have very strong support from our own community.
Earlier you mentioned the issue of the shortage of physicians in the area, and I know that part of the mission of the medical school is to address that, which I want to get to in a couple minutes. But I want to circle back to something I said earlier about the importance of population health and wellness, and speak to why that is such an important issue right now.
Well, remember that almost every country, not just developing countries, but fully industrialized developed countries, have come to the conclusion that quality health care involves more than just treating people when they get desperately sick. And obviously most people, including ourselves, we're also patients, would actually prefer to stay well, and we would prefer to get our medical care in outpatient settings and have whatever chronic disease we have managed, not only in an outpatient setting, but potentially over the phone or at home or other directions. So We at some point have to start moving in that direction because financial reimbursement in our system has historically been based on doing things to people. And so, not surprisingly, we do a lot of things to people in this country as part of our healthcare system. And the move in the future is to deliver high quality healthcare to everyone at a more reasonable price. And as soon as you start thinking about it from that standpoint, keeping people well is not only keeps them happier, but is a lot less money.
Right.
So that focus is important. But let me also point out a difference in the kind of doctor we would train. Okay. Almost all doctors, I would say all doctors, clearly feel it's their responsibility to take care of the patients that come to them individually, and that's an important thing, and we're going to teach them how to do that. Okay. But increasingly, it's also important for physicians to understand the social context in which people get sick. Okay. What are the limitations to them taking the medicine that you prescribe? Okay. Why do they have difficulty with behaviors that they know are unhealthy, like smoking or eating too much or not exercising? How can we help them do those things that will be associated with health? And that requires a deeper understanding of the social and economic environment for which our patients live, if you will, the communities that they live, so that we as physicians, in my opinion, have to not only take care of our patients, but we have to basically be the doctors for our communities. We need to be the advocates for bike helmets and jogging tracks and programs in the evenings and the afternoons for our children so that they exercise more. And it's that type of doctor that is somewhat of a change from the traditional role of physicians.
Interesting. And I know that speaking of that and the shortage of physicians, you're also looking at bringing more physicians into the area, but also training a diverse group of physicians. Can you speak to that a little bit?
Well, first let me talk about the diversity, then I'll talk about the strategy of how we get more doctors to practice here and to get them to go into the fields that society actually needs. So those are sort of three different issues. Okay. Let's talk first about the diversity issue. This is something, again, that I learned in working for years in developing countries. Whether it's Uganda or it's the Philippines or China or Egypt, they do not want American doctors coming and delivering health care to them. They want doctors and nurses and med techs and others that come from their own communities, that understand the issues in those communities to be their doctors and nurses and healthcare workers. And quite frankly, people in inland Southern California deserve the same thing. So if all I cared about was to train doctors that prescribe medicine, I can, and by the way do, teach all my doctors medical Spanish. Okay. But if I want my doctors to help my patients eat differently, exercise more, birth spacing, breastfeeding, having physicians that come from the same backgrounds as their patients is a huge advantage because they relate to their patients in a way that is very difficult for a person who doesn't come from that type of background. So, in my opinion, diversity in the physician cadre is critical to providing more than just curative care, but actually improving the health of their communities. And so we put a special value, not just in the diversity of the physicians, but that we want our physicians to reflect the communities that they're going to serve here in inland Southern California.
And I know that there are two determinants in general of where physician practices, and I think one is where they grew up, the other one is where they went to school. And just speaking of that, how does your view of the medical school help to bring physicians in, knowing that those are the two significant determinants of where they end up practicing medicine?
So if you want to address that issue, the two determinants of where doctors practice is about 40% of the decision is where you come from, equally divided between where you're born, where you went to high school, where you went to college. Now, if that's 40% of the decision, that drives a strategy, which is we better recruit our medical students from inland Southern California because that's 40% of the choice. Right. The other 40% of the choice is actually where you finish your training, which is graduate medical education or residency training. So we can't just build a medical school, we have to build graduate medical education programs in all of the specialties in short supply. If you will, the medical school for that problem is irrelevant. So if in fact I just built an ordinary med school in inland Southern California like the other 8 med schools that already existed, I would have zero impact on this problem. So despite the fact that the physician shortage drove the thinking about the med school, I can't just build a med school. I have to build a pipeline in the front end of the med school because we have the lowest college going rate, the lowest standardized test scores of anywhere in California. So I have to beef that up so I can have highly qualified candidates from my own backyard I can pick for the med school. And on the other side, I have to develop new graduate medical education programs here in our communities. And if I can do both those things, I have about an 80% chance of my students staying and practicing in inland Southern California. So that's the plan.
What I want to talk about now, since the school has opened its doors and there is an inaugural class right now, let's talk about the ideal candidate for the school, and then kind of tell me about your experience right now with the school being open.
Well, first of all, given our unique missions, there are things that you can do, given those missions, to enrich the outcome of your school based on who you pick to get into med school. So just superficially, you can tell from what I've already said, we put a high premium on students that come from inland Southern California, and particularly students that come from areas of Southern California with huge physician shortages. So when you think about that, if I had two equally prepared students, one from Coachella and one from San Francisco, there's probably nothing I can do with the student from San Francisco to ever get that student to stay and practice in inland Southern California, but I got a fighting chance to get the student from Coachella to stay in their hometown and practice medicine. So clearly we look for students from our area. In addition, we know, since we have a particular interest in training doctors to go into the fields we actually need, there are some characteristics of students that track with, for instance, careers in primary care. My own medical school for over 40 years had only one thing present on the medical school admission application that ever correlated with ultimately being a primary care doctor. And interestingly, it was previous service in the Peace Corps. Now, when you think about it, students that spend a couple years of their life to do good things for poor people in poor countries are probably the kind of students that are more likely to go into fields like primary care to care for their own communities. So we put a lot of value on service-based activities in our students. Now, it's also important, having been in the training of doctors world for many years, I'm not particularly pleased with who we're training these days. And that's because the doctors that are being trained in the United States don't have all of the qualities that I would like in my own doctor. And so in addition to mission-driven selection, we also are rethinking what are the qualities that we want in our physicians. Now, let's be clear about this. We have to have physicians that can handle the subject matter to be good doctors. So I'm not telling people that grades don't count and standardized tests don't count. But unfortunately, because the state of California is third from the bottom in the number of medical school slots per capita, obviously one of the drawbacks of California, but one of our advantages, is there are actually 10 qualified medical students in the state of California for every place in the state. So I would argue we just need to pick the right ones. Now, most medical schools pick their medical students based on who has the absolute highest grade point in standardized test score and are very proud of that. But I would argue toward the very top of that parameter, are we really selecting qualities that are important to be a good doctor? I've never heard a patient ever tell me that the most important quality of their doctor is they got an A+ in organic chemistry. I think they would prefer, they want to make sure they got an A in organic chemistry, but they want them to be somebody that cares about them, somebody that will listen to them, somebody that has a motivation to be a doctor different than just making more money. So we look at those standardized scores and performance in standardized test as a threshold. You got to do well enough so we know you can clearly handle the material and you can be a good doctor from a technical standpoint. But once you get over that threshold, we work really hard at finding the students that have the right stuff out of that pool. So we look for what is their motivation? What do they want to do with their lives? What is evidence from their background about their altruism, around caring about people? What is their connection to their own communities? Because we think those are very important qualities in making outstanding doctors, not just how smart you are. As a result, our whole selection process, although very time-consuming, is a very different process. We started late. You may know that we actually didn't get accredited our first time out because the state cut our budget, eliminated it actually. And we raised that money from our own community and went back and got accredited based on financial support from our community. But that process made us 5 months late. So every medical student in the United States had already applied to medical school and were well into that process by the time we came up on the national computer. Despite that, we got 2,500 applications for our 50 spots, probably because we're sitting here in California where there's a lot of students that want to go to med school. And out of that very competitive group of students, we actually asked about 500 or 600 to send us secondary applications because we thought that from their applications they might have the right stuff. And then out of that, we actually interviewed about 220 of them. And we actually did what's called a multi-mini interview technique based on our specific missions. So rather than just sitting down and chit-chatting with people, they would walk up to a door and they'd be given a particular prompt or question, and they'd walk in and answer that question for 6 minutes with a faculty member that would hear that very same answer from all 220 students. Wow. And based on that type of analysis, we were able to select students that were excited about our missions, that's really what they wanted to do. And we look carefully for service-based learning, we look carefully for where they came from, and the end result of that is that we then actually offered positions in our medical school for our class of 50 students. Now I have to tell you, we're a brand new medical school. We started 5 months late. We're in an area of California that if you're not from California, you have no idea where Riverside is. I wasn't sure how competitive we would be, especially because we charge exactly the same tuition as the other 5 UC medical schools. So we didn't know how many spots we should offer. When all was said and done, we only offered 83 slots to fill 50 seats. Now, most medical schools in the United States offer 2 or 3 times as many slots as their seats. And in the end, what happened is not only did we pick these students because we thought they had the stuff we wanted, they ended up picking us because they loved our mission. So almost all of our students, if not all our students, were actually accepted at other medical schools. And many of them were accepted at other UCs, but they actively chose to come to UC Riverside, this brand new school that had never graduated a student because they believed in our missions. And so what a wonderful partnering. We looked for the students we really wanted, and interestingly, those students wanted us. And so we have a wonderful class of students that really drank the Kool-Aid, and they're here to basically help us together provide for the physician manpower, improve the health of the communities we serve, and they are a very diverse group of students.
40 years from now, what would you want people to think about the school, and what would you want their perspective to be about the school?
So let me tell you a true story based on my alma mater, Case Western Reserve. In 1908, all medical schools in the United States were designed around the Flexner Report, for which courses were taught like physiology, biochemistry, et cetera, just like college courses. And the first 2 years were basic science, and the second 2 years was clinical science. In 1954, Case Western Reserve University decided we need to do something different. And they developed an integrated way to teach all of those subjects around organ systems and introduced young doctors to patients in the first day of medical school. A radical change from medical education before. Now it took 35 years, but every medical school in the United States ultimately adopted some form of the Case Western Reserve integrated curriculum. We are building a medical school that has a lot of new and innovative things in it. And if we can be successful, not only is that good for inland Southern California, but ultimately every medical school in the United States will adopt those ideas because they succeed. So what I would hope is 40 years from now, people will use University of California, Riverside as that Case Western Reserve example.
Sounds great. And one more question for you before we let you go. Just tell me about your overarching vision, which might be what you just said, but is there something that really drives you every single day, that gets you up in the morning and makes you get up and go to work and drive this very unique and new idea?
Well, I truly believe in our missions. And I believe our community deserves a medical school that delivers on those missions. And you could not have asked for a more supportive environment, a more supportive university, a more supportive community. And I gain great satisfaction in working hard to make that dream a reality. And when I really get disappointed, I just go and talk to those students, and they're the ones that keep us optimistic.
Do He knows I have one more question for you, and really what I would like for you to do is really speak to why the medical school is really good for the inland Southern California area.
You know, this medical school is uniquely designed to benefit inland Southern California. It will be a huge economic stimulus to the area. It will provide a pipeline for the physicians for not only now but into the future. It will help improve the health of our entire community. And those are the activities that are both unique to our school, but why our medical school will have a very important impact on all the people in Southern California, and that's probably the aspect I'm most proud of.
Excellent. Well, the School of Medicine certainly has the right person at the helm. I really appreciate your time today, and good luck and great success with the school and everything you're looking to do in the future, and I really appreciate your time today.
Thank you
very much. The UCR Medical School is truly going to be a trendsetter and positive change agent for the local, national, and international healthcare community. To learn more about the UCR School of Medicine, please visit www.medschool.ucr.edu. For Successful Physicians Monthly, I'm Jamar Brown.